going and learn.
Fantastic, fantastic, excellent. So thanks everybody for joining this morning. This is Petros Grivas here on behalf of my co-chair, Dr. Shalender Bhatia, a wonderful friend and colleague, as well as our great colleagues in rheumatology, Dr. Namrata Singh, Dr. Chara Chang, and others. We're delighted to host today Dr. Maria Suarez Almazor. Dr. Suarez Almazor is a full professor. Actually, she's a Barnes Family Distinguished Professor in the Department of Health Services Research and Division of OVP, Cancer Prevention and Population Sciences in the University of Texas MD Anderson Cancer Center in Houston. She has done a lot of work, meaningful contributions, and really awesome impact in the field of immune-related adverse events with a focus on rheumatologic immune-related adverse events. And despite having a busy weekend and being out of town, she was kind enough to join us this morning and share her wisdom with us. Maria, the floor is yours, and we're very delighted to have you. Thank you for joining us on behalf of our team.
Okay, thank you very much. Let me share my screen very quickly. Just a second.
Sounds great, no problem. And for the audience, guys, okay, after Dr. Suarez Almazor finishes her talk, we'll have a Q&A, so stay with us until the end. Maria, thank you.
Okay, great. So thank you very much for inviting me today. I'm very happy to join you virtually. I'm in Washington, D.C. today. So thank you very much for the kind invitation. I'm going to stop the video because I don't want any glitches while I talk to make sure that there's no stopping with the voice, but then I'll bring it up again for the questions. So yes, I'm a rheumatologist. So everything got much more interesting for us at MD Anderson after checkpoint inhibitors were approved, because that has become one of the most prevalent conditions that we treat now, the immune-related adverse events that we see with these agents. So let me, okay, for some reason, okay, there we go. Let me tell you what my disclosures are. These are all unrelated to the topic we are discussing today. And what I would like to do today is just give an overview of what are the rheumatologic immune-related adverse events that we can see. These are arthritis, polymyalgia, Zika, myositis, sarcoidosis, and very briefly some of the others. Talk a little bit about pre-existing rheumatologic autoimmune diseases, challenges in management, and then at the end, if we have time, I have a clinical case that I would like to discuss with you. And rheumatic immune adverse events are more common than what we thought. And I've taken this graph that you probably are familiar with. And the interesting thing here is that I have had to add most of the rheumatologic immune-related adverse events to the graph because initially they were not as well recognized. So this graph only had vasculitis and arthralgia. So I've had to add arthritis, Zika, myositis, polymyalgia, and sarcoidosis. So these are more frequent than we initially thought. And as I said, much of our practice is nowadays treating these rheumatic immune-related adverse events. They've been described in about 6 to 7% of patients receiving these agents, and they tend to be much more common with anti-PD-1 or PD-L1 agents or with combination checkpoint inhibitor therapy. We don't see that as much with anti-CTLA-4 or with ipilimumab. So as I said before, there's arthralgia, arthritis, polymyalgia, Zika, myositis, and sarcoidosis. I'm also going to talk a little bit about exacerbation of pre-existing autoimmune diseases. So time to adverse event for the two big ones that we see, which are myositis and arthritis, it's a little different. For you guys, you are oncologists, so you can see here in the axis at the bottom time in weeks, and usually rash and colitis are seen very early on. Well, myositis, and you've probably had patients with myositis, that also occurs very early on. Arthritis, however, tends to occur a little later. And you can see that in my graph, I have it even going out of the slide because we have had patients who have developed arthritis after stopping checkpoint inhibitors. For instance, 1 year of treatment, they stop, and a month later, they develop the arthritis, which we think it's immune related because it has some features that are a little different from typical rheumatoid arthritis, for instance, the serologies. So this is just a graph that's a little busy. This is a review that we did a couple years ago. And I just wanted for you to see the two text boxes that I have with red. In the first one is the type of immune checkpoint inhibitor. You can see that I have on the left all of the types of syndromes that can be there, you know, like inflammatory polyarthritis, psoriatic arthritis, myositis, etc. And what you can see on the right is that the majority of these adverse events do happen with anti-PD-1 or PD-L1 or combination therapy. Very rarely they occur with anti-CTLA-4 alone. Again, the time to symptoms is different for polyarthritis. The median was 3 months, but it could start as late as 24 months in the review of all of these cases. However, if we look at myositis, the median was 1 month and there were no cases described after 3 months. So there's a difference there, probably in the mechanism because of the different type of onset. So let's talk a little bit about inflammatory arthritis. Arthralgia is very common, as you all know. Arthritis is less common, and there are many patterns. Arthralgia, seronegative polyarthritis. There can also be rheumatoid arthritis-like with positive serologies, but that's less common than negative serologies. Oligoarthritis, which means 4 or less joints, and usually those are large joints like the knees or the wrists. Some patients may have what we call reactive arthritis, and they may have some systemic features such as conjunctivitis or urethritis. They may also have back pain. This is not very common, but we've seen it. Psoriatic arthritis is also something that some patients present with. And we have seen patients who only had skin psoriasis, and after they receive checkpoint inhibitors, they actually develop psoriatic arthritis. Their psoriasis gets worse and they develop the arthritis. Remitting seronegative symmetrical synovitis with pitting edema, that's a long name, RS3PE, that's how we call it, has also been described. And tenosynovitis, especially in the hands, is also a pattern that has occasionally been described. The labs, ANA can be positive in about 30% of the patients, rheumatoid factor and anti-CCP, and like rheumatoid arthritis, they are not as common. So 90% of the patients that we see with arthritis do not have these serologies that are positive. SED rate and CRP are very useful to us because they are usually quite high in patients with arthritis, and they can help us distinguish from patients who may have osteoarthritis and just are having a flare from the osteoarthritis, which we can also see with checkpoint inhibitors, and I'll talk about that in a minute. Typically, when we see these patients, we get a T-spot and we get the hepatitis and HIV serologies because sometimes we need to treat them very quickly with biologic agents, and we want to make sure that we don't make them worse if they have pre-existing infections. So we usually do that early on, even if we are just starting to treat them with steroids. The imaging is not very helpful. There are some studies that have looked at ultrasound and MRI, but it's all very non-specific. It just shows soft tissue swelling with synovitis. I'm just showing this slide because unlike some of the other immune-related adverse events that you can see, like colitis, which you treat and it goes away, with arthritis, sometimes it tends to linger, and we have seen patients who actually develop erosions, almost like rheumatoid arthritis. So again, this is a little different from other immune-related adverse events because it's chronic and persistent, but imaging doesn't really help you to distinguish this from another inflammatory arthritis from typical rheumatoid because the findings are very similar. Okay, this is a systematic review of arthritis cases that I wanted to show. And again, it's a busy slide, but just show, I just want to comment or show what is in the text box with red. So again, if you look at the type of agent, the majority of the cases were with anti-PD-1 and anti-PD-L1. Of course, this is not true frequency based on the denominator because we know that anti-PD-1, PD-L1 are used more than anti-CTLA-4 alone. But even so, in studies that have looked at the denominator, it occurs more frequently with the anti-PD-1 or with combination therapy. Again, as I mentioned before, months to onset. In this particular review, it was 4 months, in the other one, 3 months, and it can occur as late as 53 months. The clinical presentation in this systematic review, again, polyarthritis was the most common, but usually these tend to be seronegative. Oligoarthritis, which is just a few joints. Monoarthritis is more rare, and some patients also have polymyalgia-like syndromes, which I will discuss after arthritis. The pattern of rheumatoid arthritis here, it says 65%, but it really doesn't take into account the serology. When we look at patients with primary rheumatoid arthritis, 80–90% of them have positive serologies. However, in these patients with immune-related arthritis, you can see here that rheumatoid factor anti-CCP were positive only in less than 10%. And ANA can be positive in a larger proportion, in about 30%. This is a patient that we had that developed typical rheumatoid arthritis, and she was actually seropositive. She had lung cancer, and you can see that she has inflammation in her PIP joints. She never had rheumatoid arthritis in the past, but after receiving the checkpoint inhibitor therapy, she developed typical rheumatoid arthritis. And there are some descriptions of patients who actually had positive serologies before they received the checkpoint inhibitor, and then they develop the disease. So in those patients, we tend to think that it's probably subclinical disease that is manifested after receiving the therapy. Okay, so treatment recommendations. From a rheumatology perspective, what we really want is to be able to have the patient continue the immune checkpoint inhibitor. That's very important to us, and we understand that cancer is the most important issue because other than myositis, the other diseases that we treat are not life-threatening. Maybe vasculitis, but we don't see that as often. But with arthritis or polymyalgia, it's not life-threatening. So for us, it's very important that the patient can continue with the immune checkpoint inhibitor. But we also want to improve quality of life. Steroids, usually we try to start with 20 milligrams of prednisone, but if severe, sometimes we need to use higher doses. This is also very different from rheumatoid arthritis because with rheumatoid, we usually treat patients with 10 milligrams or lower. Many patients are on 7.5 milligrams, and we usually try to keep them off steroids using disease-modifying anti-rheumatic drugs or DMARDs. So we find that for these patients with immune-related arthritis, we need to treat them with higher doses of steroids to try to control the arthritis. But we try to decrease as soon as we can. So one of the things we do is use DMARDs early on if we see that the steroids cannot be tapered, because if the patient continues to receive the checkpoint inhibitor, they will continue to have symptoms. The issue is what DMARD should we use? And there are practice variations across continents, countries, and also across centers. So just to give you a little bit of background of what we use in regular rheumatoid arthritis or in some of the other inflammatory arthritis that we see. Nowadays, we divide our DMARDs into three classes, what we call conventional synthetic, and that's methotrexate, leflunomide, hydroxychloroquine, and sulfasalazine. What we call targeted synthetic DMARDs, and those are JAK inhibitors. Those are the ones that have been approved. The one that was approved first was tofacitinib. And then biologic DMARDs, and there are a number of those. TNF inhibitors, IL-6 receptor inhibitors, abatacept, which is the opposite of ipilimumab, is a CTLA-4 agonist, rituximab, IL-1 and anakinra, that's very rarely used. It's approved for rheumatoid arthritis, but we rarely use it. In Europe, they use a lot methotrexate. This must be, and now I'm talking about immune-related adverse events. They tend to use a lot of methotrexate. This might be due to coverage issues, and most countries in Europe have universal healthcare, so they have to practice according to guidelines, and they may require methotrexate use probably, and that might be one of the reasons. In the United States, we tend to use biologics earlier. At our center, we use a lot of IL-6 receptor inhibitors. Basically, tocilizumab is the one that we have been using. One of the reasons is that the response is a little faster than with methotrexate, where it can take up to 3 months until you see a response. However, it's unclear if there are any advantages to either approach other than acting faster. We really don't know if there are effects on tumor immunity, and I will talk a little bit more about that towards the end of my talk. This is we were one of the first ones to report the use of tocilizumab in patients with arthritis. This is a busy slide again. It's only showing 3 cases, but what I wanted to show you, I mean for you because you're oncologists, if you look at the lines, I hope you guys can see my mouse. I mean, this is how, you know, this is pain, this is tender joint, and here you see how it decreases, okay? In case 3, I mean, case 2 had a little flare, but even case 3, you can see how it decreases, and these are the months. You can see that it takes a long period. And like, for instance, colitis, where you give steroids or infliximab and patients respond right away, I mean, it may take 2 months, okay, for arthritis to respond. And this is tocilizumab. So it took 2 months until it subsided. So sometimes we get questions such as, oh, is this working? The patient received this 6 weeks ago. There's still not improvement. Well, arthritis takes longer to get better than some of the other immune-related adverse events. And that's important to remember because it doesn't necessarily mean that the drug is not going to work. It's just that it takes a little longer. So this is the review that I was talking about, that reviewed all the cases for arthritis. And you can see here, if you look again at the red squares or rectangles, I should say, steroid usage, 74% of the patients. Of those, close to half require more than 20 milligrams of prednisone, which is much more than what we use for rheumatoid. As I said already, rheumatoid, we usually start with 10 milligrams, and we like to keep patients with 7.5 milligrams, so a lower dose. And that's what we would hope for these patients, but sometimes it's a little difficult. About a third of the patients required DMARDs, and some of them required biologic agents. Again, this is a series of cases, and some of them are from Europe. They are not all from the States. And then what I have at the bottom is that some of the patients did okay, but as you can see, they require treatment. Okay. This is these are 3 graphs. They are a little busy, but I'll walk you through them, which are interesting. They show persistence of arthritis according to some characteristics. So in graph A, what you can see here at the bottom, you have the follow-up in months, okay? And you have 2 curves. This curve here is patients that received monotherapy, and this curve here is patient who received combination therapy. And you can see this is a typical survival curve. So for those who received combination therapy, they had much more persistent arthritis, or much more often persistent arthritis, than those who received monotherapy alone. But even for those with monotherapy, if you look here, this is 10 months, okay? So, I mean, at 10 months, still 50% of the people had persistent arthritis. So very different from other immune-related adverse events. Here we have the same graph on persistent arthritis according to how many adverse events patients had. So if they had 2 or more in addition to arthritis, the arthritis was more persistent. If they only had arthritis or 1 other adverse event, the arthritis tended to resolve a little earlier. And now the good part of it, those who had a complete or partial response had more persistent arthritis, but those who had progression, the arthritis resolved better. So as you know, for other adverse events as well, it would appear that having an immune adverse event, if it's not too severe, it can actually help you with the tumor response. The differential diagnosis for this type of arthritis, metastatic disease, septic arthritis, paraneoplastic syndromes, and there are other causes of musculoskeletal pain that can be exacerbated with checkpoint inhibitors, such as crystal-induced arthritis, osteoarthritis, or tendinitis. So let me walk you very quickly through a case. This is a patient, a woman who had vulvar melanoma, and then she also had systemic lupus erythematosus that had been diagnosed before the melanoma, and it was mild lupus, mostly arthralgia, oral ulcers, hair loss, positive prior pleuritis, but it was considered mild to moderate lupus. So her labs were typical of lupus, ANA, and double-stranded DNA. So at the time when she was diagnosed with melanoma, she appeared to have mild lupus, and she was stable and was only treated with hydroxychloroquine. So she developed metastasis in 2015. They asked us, can the patient start with anti-PD-1 therapy? We said yes. So she started with pembrolizumab. She had just tenosynovitis in her thumb, but we gave her an injection. She did very well, no major lupus flare. Unfortunately, she did not respond well to the pembro. There was tumor progression, so they asked us if she could receive ipilimumab. We said yes, because again, we recognize that the cancer is the most important thing here. So she had a little bit of a rash, some arthralgia, and skin itching after infusion, but no major lupus flares. And she completed 4 infusions, tumor progression again. So they started her on Nivo. So she had severe pain, imaging that suggested metastasis in the back. So she started radiation. And after 3 doses of Nivo, she was admitted to hospital with severe pain and swelling of the right shoulder and some pelvic pain. So they consulted us and they said, well, will you give her an injection because she has developed arthritis, immune-related arthritis. So we asked for an MRI. So this was not arthritis. She had metastatic disease to the shoulder. So again, this is a differential that's important to take into account because we may miss it. So the key points for arthritis, it can be pleomorphic, as I said, oligoarthritis, polyarthritis. It can be with positive serologies or not. It can occur later on, even after termination of checkpoint therapy. It's worse with combination immunotherapy. Most patients are seronegative. Some patients have been found to be seropositive before initiating therapy and then develop arthritis, and this might have been subclinical rheumatoid arthritis. Importantly, it can become chronic and erosive and require treatment for months with DMARDs or biologic agents, and it's more difficult to treat. And the goal is really to try to maintain the checkpoint therapy if the patient is responded while trying to minimize symptoms. So let's talk a little bit about polymyalgia. Polymyalgia is usually presents with proximal upper and lower extremities. What is different from primary polymyalgia is if we look at our criteria that we use in rheumatology from the American College of Rheumatology, the criteria require that there be no arthritis. However, in these patients that we see that have polymyalgia after checkpoint inhibition, they actually may present with arthritis as well. Polymyalgia, primary polymyalgia can be associated with giant cell arteritis. We rarely, very rarely, there's only case reports, see this with checkpoint inhibitor immune-related adverse events. It improves with discontinuation of the therapy and steroids, usually flares if you continue with the checkpoint inhibitors, and sometimes they require IL-6 inhibition, which is a treatment that's approved for giant cell arteritis. It's not approved for polymyalgia, but sometimes we use it for patients who are very severe with primary polymyalgia. So we also use it for polymyalgia secondary to checkpoint inhibitors. This is a series that was published of 20 patients. I think there are many more right now. This is from Cleveland Clinic and also a review of cases of the literature. Median time to onset, 3 months. And as I said before, almost half of the patients also had arthritis. Most of them were seronegative, and some patients require higher dose of corticosteroids. For primary polymyalgia, we usually treat them if they don't have vasculitis. Vasculitis is a whole different story, but we usually treat them with 20 milligrams of prednisone or so. So sometimes for these patients, we require higher doses. And again, a couple of them require tocilizumab for symptom control. SCCA syndrome is also a little different from primary Sjogren's, okay? Dry mouth is more common than dry eyes. It tends to happen very acutely. So patients who develop primary Sjogren's, usually it's an onset that takes years before they go to the doctor. In this case, with the SCCA that we see after immune checkpoint inhibitors, usually it happens like in 3 days or in a week. They can have swelling of the salivary or parotid glands. The Schirmer test, which is a test in the eye, might be negative because, as I say, it's more common in the mouth than in the eyes. The differential diagnosis is whether they are taking other therapies. As you know, with antidepressants and with chemotherapy, dry mouth, dry eyes are very common. Interestingly, primary Sjogren's is almost 90% of the times positive for SSA, but here very few patients have positive SSA, and some patients may need steroids. So this is a review that we did of cases around the world from a registry that we have, and it's comparing Sjogren's syndrome triggered by immune checkpoint inhibitors compared to primary Sjogren's syndrome. So the age is different, but again, that's also related to the patients who have cancer. Primary Sjogren is primarily in women, but here with ICI, we see it more commonly, or at least the same in men. But again, that's because there's probably the same number of men and women that receive checkpoint inhibitors. When we look at the bottom here, you can see that in the Sjogren triggered by ICI, the dry eyes and the ocular tests are not positive all the time. In primary Sjogren's, almost everyone has dry eyes, and the Schirmer tests or the eye tests are positive most of the time. Then if we look at the serologies, again, for the ICI-induced, the serologies are positive in less than half of the patients, but for the primary Sjogren's, most of the patients have positive serologies. The interesting thing in the histopathology, there's a lot of T cells that are there, very few B cells. In primary Sjogren's, there are a lot of B cells, okay? So it would appear that the pathogenesis of these disorders is not the same, or at least there are some important differences. So let's move on to myositis. This is the one we are all scared because this is the one that's really serious for our patients. It presents clinically as polymyositis, so with no rash. With rash, we would call that dermatomyositis. Interestingly, many patients have myalgia in addition to weakness. Primary polymyositis, not induced by checkpoint inhibitors, usually is weakness alone. It doesn't hurt, okay? But we think in these patients there's pain because it happens much more quickly. It's more acute, and some patients have necrotizing myopathy, and some can even have rhabdomyolysis. The most important thing, watch for myocarditis and for myasthenia gravis. That's the famous triad. That's very, very severe. It's more common with combination immunotherapy, and we think that this is a de novo inflammatory manifestation. It's not an uncovering of paraneoplastic dermatomyositis, although there are a few case reports of dermatomyositis after checkpoint inhibitors, but the majority of these cases are this myositis that's very acute and very profound. This is a paper that we did of our experience at MD Anderson of 9,000 patients that had received checkpoint inhibition. 36 developed myositis, so under 1%, 3 times more common with combination immunotherapy than with monotherapy, and median time from initiation was 27 days or 2 doses. Very severe symptoms. Close to a third had rhabdomyolysis, and over half had overlap manifestations with myocarditis, myasthenia, or both. So the antibodies are not present all the time. What tends to be a little more common is the anti-striated muscle antibody and anti-acetylcholine receptor antibody in those patients who have overlap with myasthenia gravis. Something that's important, some patients had normal CK but had elevated aldolase, and these were biopsy-proven patients, so we tend to ask for aldolase as well. Troponin T elevations and troponin I elevation was common in both groups, and the histology was non-specific, but importantly, about a third had muscle necrosis. So myositis alone, if you don't have myocarditis or myasthenia gravis, has a very good response to steroids and ICI discontinuation in most of our patients. The CK normalized very quickly, and most had no further flares, and the prognosis was dependent more on cancer response. However, those who had overlap with myocarditis or myasthenia had bad outcomes with mortality attributable to myositis in over 40% of the patients. Importantly, a third of our deaths had concomitant sepsis because we treat these patients very aggressively to try to control their myocarditis and their myasthenia and their myositis, and unfortunately, sometimes infection is a complication. So the key points when suspected, act quickly, ask for aldolase and troponin, cardiology and neurology consultations, discontinue ICI, consider plasmapheresis. That's what we do, but it's really empirical. There's no control data. And also be watchful for sepsis. Rechallenge is usually not advisable. So sarcoidosis, we have seen a few cases, and usually they present, there's also a review from that registry that I was mentioning before, that we participate in several countries that give cases. So usually what it affects most often is the lungs with big mediastinal lymph nodes, and very commonly also the skin. Okay, but it can also affect other organs. Patients can have hypercalcemia, and some of them, about 25%, had elevated ACE, but the majority do not have ACE. So some of these patients require steroids, but usually they resolve after discontinuing the checkpoint inhibition, and about 40% of them were able to continue treatment. So this is one patient that we had never had a history of sarcoidosis and actually developed skin nodules over the area of the tattoos. Also had nodules in the tendons, but very interestingly, some of the skin manifestations were in the areas where he had ink because of tattoos. This patient here actually had a very remote history of sarcoidosis about 20 years before she started immunotherapy, and she developed, I mean, this is a very typical of what we saw with those cases. So the hilar lymphadenopathy, the skin nodules, and then arthritis in her ankles. Other rheumatic immune-related adverse events are rare. Systemic lupus erythematosus with full systemic features is rarely described. What is seen more often is lupus-like skin rash or subacute skin rashes, but we don't really see full flare systemic lupus. Vasculitis is also rare. GCA, leukocytoclastic vasculitis have been described, but it's also not very common. This is interesting, crystal arthritis. There's been reports of gout flares and also of pseudogout flares. This is a case that we saw at MD Anderson that we published. It's a patient who had no prior history of arthritis, but had damaged his left knee in sports when he was young. He was now 63. After 14 infusions of nivolumab, he had left knee swelling. So the synovial fluid showed CPPD. We gave him an injection. He improved. So he had 2 more episodes with each infusion, like a week after the infusion, he would develop the arthritis. So we treated again with steroid injections. So then, I mean, this was my patient. So I thought, well, what if I start colchicine, which we use more commonly for gout. So daily colchicine. So that was great. He never again had arthritis of his knee and was able to continue Nivo without any further episodes. This is a new case series that has just been published last month. It is a retrospective case series of patients with osteoarthritis, and actually these patients had exacerbations of the symptoms, okay? They all received PD-1 or PD-L1 agents or combination therapy, and about 2/3 had elevated CRP. So what's the difference with inflammatory arthritis that I discussed before? The difference is that these patients can be treated with local injections, with NSAIDs or physical therapy. So you're not necessarily going to need to give them steroids or DMARDs. They respond to more conservative therapy. So that's where it's important to have an accurate diagnosis and try to see if this is osteoarthritis. And in this particular case, imaging might help you because you would see clear features of osteoarthritis. So very quickly, I'm going to talk about immune checkpoint inhibitors in autoimmune diseases. So I'll show you one slide. This is a case series that we a systematic review of case series that we did. Now we are updating this. About 75% of patients who have pre-existing autoimmune disease may have a flare of their disease or may have another immune-related adverse event. So for rheumatoid arthritis, about half of them had a flare. With psoriasis and psoriatic arthritis, about 80% had a flare. We didn't find many differences between patients with active or inactive disease, but those who had immunosuppressive therapy at the same time as they receive the checkpoint inhibitors appear to have fewer adverse events. The important thing here is what I have in orange at the bottom. Adverse events improved in half without permanent discontinuation of the ICI therapy. This is pretty much the same. So challenges in management. Okay, as I mentioned before, one of our goals as rheumatologists is to try to let oncologists do their job so patients can continue treatment. But we want to maintain quality of life and also limit mortality and severe morbidity. So how do we know if the treatments that we use are good or not for the cancer? Well, it's very difficult to know with the data that we have. There's three things we can do. We can look at patients who have autoimmune diseases who are treated with these agents. Do these agents cause cancer per se in these patients? And there's a lot of data on that. The second thing we can do is look at patients with autoimmune disease and cancer and see if when we are using these drugs, there are recurrences or there's increased mortality. And the third thing is look at the patients who actually have immune-related adverse events and see what happens when they receive the therapies to treat those adverse events. Unfortunately, there's only small series. So number 3, we don't have a lot of data. Okay, so I'll show you a little bit of the other data. So one of the problems that we have is that we know immune-related adverse events are associated with better prognosis. So that may obscure the bad effect that we can get from this specific treatment like steroids or DMARDs. Because on one hand, we get better prognosis because you got an immune-related adverse event, and on the other hand, the therapy might be bad for you, but because the immune-related adverse event is associated with better survival, that obscures the effect, okay? So this is very busy, so I'm just going to cover what's in red, but it's just to know that there's data. The Swedes have very good data because they have universal registries for all patients with rheumatoid arthritis who receive biologics. So do they have any signals that any of these biologics can cause cancer? We used to say, well, TNF inhibitors can cause lymphoma, We don't know for sure. The only signal that appears to be happening more consistently is abatacept, okay? There's an increase in malignancies in patients who receive abatacept, okay? This is for squamous cell, but there's another slide that I'm going to show you. And why is this important? Because abatacept is a CTLA-4 agonist. So it's the opposite of anti-CTLA-4, okay? So it seems to be associated with an increase in cancer in patients with autoimmune diseases. This is again the Swedish registry. You can see that TNF inhibitors, rituximab, tocilizumab, they are not associated with an increase, okay? But abatacept increases by 20% the risk of having a malignancy spontaneously in a patient with rheumatoid arthritis, okay? The other thing that we know, and this is a review that we did, is, well, and we don't know that very well either, but if we use TNF inhibitors in patients who have rheumatoid arthritis and cancer, do we increase the risk of recurrence or do we have worse survival? So as you can see, the data here, most of these studies did not reach statistical significance. So there might be some signals, you know, a little bit above 1, that TNF might be bad for your cancer when you receive it if you have rheumatoid arthritis, but the data are not statistically significant. And because the outcomes and the type of cancer are all over the place, unfortunately, we cannot do a meta-analysis. This is pretty much the same. There's only one study in Medicare that appeared to increase non-melanoma skin cancer that was statistically significant. But again, we don't have a lot of data from there. Rituximab appears to be fairly safe in patients with cancer, and it's used for cancer, as you know. And this is just on breast cancer, use of TNF inhibitors. And for breast cancer, there appeared to be no risk when they compare patients who received TNF inhibitors and had rheumatoid arthritis and breast cancer versus those who did not, okay? So it did not increase cancer recurrence. Let me go through this. Okay, so what happens when patients are receiving immune checkpoint inhibitors? Unfortunately, we don't have a lot of data. We know that that patients who are receiving steroids for other reasons, asthma or whatever it is, when they start checkpoint inhibitors, they have worse tumor responses. TNF inhibitors appear to have no adverse effects, but they are mostly used for colitis. So usually there's only a couple of infusions that are given. And for arthritis, we actually need to treat them, as I showed you before, even up to 2 years. So there was one study that did show worse cancer outcomes, but other studies have not. TNF inhibitors have opposing immune effects against tumoral cells. Tocilizumab has anti-tumor effect in animal models, so that's one of the reasons why sometimes we use that before we use TNF inhibitors. And then the effects of steroids versus other DMARDs, that's very difficult to disentangle because almost everyone receives steroids first. So there are no good control studies that compare steroids versus DMARDs without steroids. So it doesn't help us with the decisions. This is just to show you that, and this is a conceptual framework by Ambassador's group that has put together all the effects that have been described for TNF inhibitors. So you can see that there's green and there's red, some are good and some are bad with respect to tumor immunity. So again, basic science doesn't necessarily help us. Corticosteroids, patients with cancer often receive corticosteroids for various indications, and there haven't been bad signals there, but conceivably they could impair tumoral responses. We use them very quickly because of the quick response and as bridge therapy, but those are short-term dosages sometimes, and in patients with rheumatoid arthritis, not necessarily checkpoint inhibitor. So again, the data is conflicting. There's theoretical data based on basic science study, but there are very few controlled human studies that can tell us whether this is good or bad. So again, this is also a graph that shows that glucocorticoids can be good in some instances, but they can also be bad in some instances. So if you're interested, this will be in my slides if you want to read a little bit more about it. So in summary, rheumatic immune-related adverse events can occur in about 7% of patients receiving immune checkpoint inhibitors. They are more common in those receiving anti-PD-1 or L1 monotherapy or combination therapy. They can occur late and even after we discontinue treatment. The arthritis can be very pleomorphic, and it's important to distinguish from osteoarthritis. There can be polymyalgia-like syndrome present with arthritis, and the one we really worry about is myositis. Always check for myocarditis and myasthenia gravis because the prognosis is very poor for those patients. For patients with pre-existing rheumatic or immune diseases, we think they can receive immune checkpoint inhibitors. We know that about half of them will flare, but the flares can be managed. And as I say, we think that the treatment of their cancer is more important. So this is what I had as far as my presentation. I had a case, if you're interested, or if not, I'll just take questions. I'll leave it up to you guys.
Maria, fantastic overview of the data. This is amazing how much you covered. Why don't you go through the case? Shalender, would you agree with that? And then we can go to Q&A.
Yeah, we can do that. Maria, I have to say special thanks to you for covering. We will lump it as rheumatologic irAEs, but we realize this is not just one disease. These are 10 different diseases that you covered in 40 minutes or so. We gave you the impossible task, and you did such a fantastic job with the overview. There were lots of questions coming on in chat, and I promise everybody that we will get through all of those. In terms of just organizing our Q&A, I think one way of doing that may be to just break it down into various sections. Like, for example, we can talk about epidemiology. There were some questions on mechanisms of irAEs. Are they pre-existing? Are they antibody mediated, T-cell mediated? There were questions about diagnosis and presentation, and then a lot of questions on treatment too. So I think we can go through all of those. How long is your case going to take?
Well, I can go very quickly, 3 or 4 minutes. Yeah, I think it's 3 or 4 slides. Yeah.
Okay.
I can. I mean, it's an interesting case because it was a challenge for us. I mean, it's a typical case that I'm sure you see, but I mean, I can do it quickly. It's on myositis because that's the one that we are always very concerned about.
Okay, well, how about we do the case, and maybe if there are questions
Okay.
on myositis, we can deal with those questions, because I agree myositis is more life-threatening, and let's talk about that.
Okay, so I mean, some are graphs, but I'll show it sort of quickly. Let me, oops, for some reason it's not moving. Ah. Sorry. Oh, there we go. Okay, so this is an 81-year-old male with metastatic melanoma who received nivolumab. And then after one infusion, when he comes back for the second infusion, patient had an increase in CK and was admitted. The CK was high, aldolase was high, troponin T was high, troponin I was high. Interestingly, patient had no cardiovascular symptoms at all. He had a history of coronary artery disease with stent placement, but had no cardiovascular symptoms, no muscle weakness, inflammatory markers within normal limits. So patient underwent a biopsy of the muscle and the myocardium, and he received 1 gram of solumedrol, mostly on the basis of the increase in troponins and the concern about the heart. So oncology decides to hold on the steroids, given lack of symptoms until biopsy. So we start PLEX. Then he has EMG that favors myopathic process, no neuromuscular joint dysfunction, no muscle weakness still, no severe symptoms, heart echo MRI, patient had an apex aneurysm, but no evidence of myocarditis. The biopsy of the myocardium, no myocarditis. The muscle biopsy does show inflammation and myositis, but patient did not have weakness. 3 cytokine panel, interferon normal, TNF elevated, IL-6 very highly elevated. And then on 825, because it was persistent enzyme elevation, patient is started on high dose steroids. And then he receives tocilizumab as well. So there is a decrease in CK, a decrease in troponin, and troponin I, which is more specific for heart, but troponin T remains elevated, muscle strength still preserved, and patient is discharged on 200 milligrams of prednisone, PO, a very high dose, but with a taper plan. So this is just to show you a little bit what happened. CK, first arrow is the first admission at discharge, very low after he received treatment. And then the patient was admitted again, I'll show you again. And at the time of admission again, the CK was pretty much within normal limits or close to that. Aldolase, it lingered a little more, but on second admission, it was lower. Troponin I decreased, and at second admission, it was close to normal. But troponin T, and that's something that we find very often, and we don't know why, remained elevated throughout. So patient is admitted again because of weakness, severe hyponatremia, progressive shortness of breath, dysphonia, mild ptosis, but his CK at that point was normal. So he's given high-dose steroids pulses instead of what he was getting, Plex, and then 917, he's intubated. The EMG shows now evidence of myositis and myasthenia gravis. Then he has positive anti-acetylcholine receptor and anti-striated muscle antibodies. We start to decrease steroids, among other things, because in primary myasthenia gravis, it's not recommended to give very high doses of steroids. And in these patients, we don't really know how to treat them, whether we should give high steroids or low steroids. And the neurologists don't even know what to do. So we start Plex first, and then we complete the Plex, and then we give IVIG. So anyway, the patient is intubated, as I say, but then within 2-3 days develops infection, and then the family decides to extubate, and patient dies right away. So this is the case. It was very challenging for us because the patient, when admitted, almost had no symptoms. I mean, no weakness, nothing in the heart that we could document, echo normal, biopsy normal. We treated patient very aggressively, and patient, 1 dose of needle and died. I mean, he was an older gentleman, but this was a very challenging patient for us. I mean, it just happened, so that's why I decided to present it. And I don't know if you've had similar cases or you have any comments about this. So this is it.
Yeah, well, that's very, very dramatic. I am actually, I got curious when I was hearing it. We don't check CK levels routinely unless it's on a trial. And I don't know about the other oncologists on the call, but is that your standard practice at MD Anderson?
I don't, I mean, I would have to go back to the chart. I don't think that this was because they do it standard. What happens is that with the muscle, you get increases in LFTs. Okay, transaminases are in the muscles also.
Yeah.
So I think what happened is that he came back and then the CMP showed an increase in transaminases. And when they see that, they usually ask for CK if there's no reason to think that there is liver toxicity. Okay, because transaminases are in the muscle. So typically that's the first thing you see because we don't ask CK routinely. But in this particular case, I don't remember if that was asked, the oncologist asked for it routinely. But I know that the patient had increased transaminases, and I think that's probably why they requested the CK.
Okay.
If you see an increase in LFTs and there's no reason to think the patient has anything in the liver, just think that the transaminases may be coming from the muscle. Okay.
Yeah, especially an LDH as well, I think, for that reason. So.
Yeah, exactly. And LDH as well. Yeah.
Yeah. So looking back at this case, would you do anything different?
I mean, I don't know. I've been concerned a little bit about the high dose steroids in patients who have myasthenia gravis like syndrome because, and again, I mean, I'm not a neurologist, but because there's been descriptions of patients getting worse with high dose of steroids, I wonder if, I mean, I don't know what could have been done differently. I mean, we are shooting in the dark because we don't know the mechanism for this. I mean, we don't know if it's T cell, B cell. I mean, if you look at the biopsies, it would appear that it's more T cell induced, but some patients have autoantibodies. That's why we use Plex. I wish I could tell you more, but I think we are shooting in the dark for the most part.
Yeah, and my general impression dealing with similar cases, not exactly this diagnosis, but similar cases where we don't understand the pathophysiology, but the consequences are going to be dire if we do not treat aggressively. My general approach has been hit them hard early on with keeping all those possible mechanisms in mind. And I think we have a better chance of successfully coming out if we hit them hard early on, even at the cost of more immune suppression, rather than doing a stepwise progression of immunosuppression, where then you start building up immune suppression chronically. And that, I think, also affects the predisposition to get infections and so on. So that's kind of my just general principle that I would like to follow from my experiences over the years.
Yeah, I mean, half of our patients with myositis that died, they died with sepsis. So, and they were treated very aggressively at the beginning. I mean, this happened, but it really happened over a period, of a couple of weeks. So, I mean, they were treated, or the other ones as well, very aggressively. I mean, I wonder if maybe using antibiotics prophylactically, even before they have anything, would be an option in these patients. I mean, I don't know, but. Again, I mean, it's very challenging without knowing exactly what the pathophysiology is. I mean, in rheumatology, and again, we are talking chronic diseases, at one point in time, combination therapies of biologic agents were tried, and none of them were approved. The trials had to be stopped because the infection rate was so high. And for our diseases, even vasculitis, we never use two biologic agents together. We might use high-dose steroids, a biologic, combine it with methotrexate, things like that, but we don't use, I mean, here sometimes, and we are always scared from rheumatology to do it, but the oncologist may push, and then they've received rituximab and tocilizumab. In rheumatology, we would never do that because the experience has shown that the risk of infection is very high. But on the other hand, I mean, these patients die, and this gentleman was 81 years old, but this could happen in a 33-year-old patient with melanoma, one single dose of nivolumab, So.
And Maria, this is really eye-opening case, and thank you for presenting this. It shows you that things can go the wrong way very quickly and rapidly.
Uh, the question I had initially, going back to Selender's comment, the patient had a biochemical, increase of CPK, aldolase, troponin, but initially had no symptoms. So, the initial approach was probably aggressive enough, right? Despite the presence of symptoms, he got, immediately workup, biopsy, and the high and solumedrol. So, would you recommend empiric treatment, even without, in the absence of symptoms, in very high elevations of enzymes without other causes?
I wish I could answer that. I don't know, because in this case, obviously, I mean, it didn't work. The patient didn't get better, it got worse because he didn't have any symptoms, and then developed myasthenia gravis when he was released from hospital. At the beginning, when he was admitted, he didn't have any, we didn't suspect myasthenia gravis at all because he had an EMG that showed just myopathic changes. And, the CK was very elevated. When you have myasthenia gravis, you can have an elevation, but it's usually 800 or so. I mean, it's not like in the thousands. So that was not suspected at all. And we didn't think he had, the deadly triad. And then the biopsy of the heart was negative. I mean, what's something that we find though is troponin T, and sometimes that's persistently high and the patient has no symptoms. CK comes down and we are treating because there is an enzyme that remains high. And I think that's I think troponin T probably takes a little longer to get cleared by the body, and that might be why. But in this particular patient, I mean, he was treated very highly, as you say, on the basis of biochemical and histopathology, because the muscle biopsy did show myositis, but the patient was well. I mean, was walking, was normal, then goes home and comes back 2 weeks later, in horrible shape, despite being on 200 milligrams of prednisone, which was a dose that we got given him. I mean, it wasn't me because I wasn't on call on that particular week, but he had been given a tapering schedule to follow, but because he wasn't feeling well, he didn't taper and came back to hospital. And despite that, he did very poorly. So, I mean, very challenging. For me, if anything, it has made me even more uncertain as to how we should treat these patients.
Yeah, tough case indeed. So we have half an hour. So I would propose maybe just talking about different categories here and deal with questions. I'm sure people have lots of questions about all aspects of it. But maybe if we can go to maybe diagnosis or actually presentation and epidemiology. So one of the, Sarah Chung put this in the chat, that the mechanism of pathogenesis of these diseases, immune complex or antibody mediated versus predominantly T cell mediated. What do you think is going on? Sarah says irAEs seem predominantly T cell mediated, whereas immune complex mediated diseases like SLE or small vessel vasculitis are relatively uncommon. Do you think it's that? Yeah.
I mean, again, we don't know enough, but antibody related is not necessarily immune complexes. I mean, there's been instances even for hypophysitis where they have seen that there are some anti-CTLA4 antibodies. I mean, anti-CTLA4 antibodies can actually, this would be a little different because it's this direct attack, not by creating your own system antibodies, but ipilimumab, there's CTLA4 that express in the hypophysis. So whether that has any direct effect from an antibody, that's one area. The other area is that we can have, even with rheumatoid arthritis, okay, with rheumatoid factor, which is an antibody and anti-CCP, we don't even know how those actually cause disease. I mean, we don't know that it's an immune complex. So it's some effect that the antibody have directly over the tissue, but we don't even know if this is cross-reactive or if it's not. I mean, it's difficult to know. So it's not necessarily immune complexes, okay? What we know in these patients, and actually I was reading before coming here, last week about antibodies, and there's a couple of studies that have looked at antibodies with big panels, of doing proteomics types of analysis, and they actually find a large number of autoantibodies in patients who have these immune-related adverse events, even with pneumonitis and with some of the others. I mean, are these pathogenic? Are these bystanders? Because there's so much damage in the tissue, then there are antigens that are exposed, and then you create antibodies against those antigens, but they don't have a pathogenic effect. I mean, it's hard to know. It is true that you would think that a lot of these would be related to T cells, because what you are doing with the agents that you're using is increasing T cell activation, but T cells and B cells work together as well. And we use plasmapheresis at all because we think it removes antibodies and immune complexes. So again, do I think it's just a single thing? Maybe not. Maybe it's a number of different things that are happening. And it's, I mean, obviously T cells may even be cross-reactive. You may all be familiar with a study that was published in New England a couple of years ago on myocarditis, where they actually found T cell cross-reactivity between the tumor and the myocardium. So that can also be, I mean, there's many different things that may be happening. There's also the patients who may have subclinical pre-existing disease, as I was saying, with rheumatoid arthritis, and then you give them this, you enhance their immunity, and then what was subclinical suddenly becomes clinical. There can be T cell cross-reactivity. There can be autoantibody cross-reactivity. We don't know if the microbiome plays a role. As you know, the microbiome is important in tumor responses. Patients who have different microbiomic profiles, they respond differently to checkpoint inhibitors. They may do better with a certain profile. So at the same time, because we know that there is some relationship, I mean, not a correlation of one, but immune-related adverse events tend to be associated with a better response. It could also be that the microbiome plays a role, okay? In rheumatology, we have reactive arthritis, which we think are very much caused by the type of infections or by bacteria that you may have in your body. And some of these arthritis that we see, especially oligoarthritis of a few joints, they really look like reactive arthritis, but there's no data. No one, I mean, people are looking into this, but there's no data yet to suggest that some of these could be also related to your own immune response to your microbiome that's enhanced with the checkpoint inhibitors. One of our faculty is doing some studies in synovial fluid. What he has found is that there is an increased Th17 response. There's also interferon signal that's very strong, which is interesting because interferon, I mean, lupus is an interferon disease, and we don't really see a lot of lupus-like syndromes with checkpoint inhibitors. We see rash, but I mean, I haven't had a single patient with full lupus with pericarditis, the oral ulcers, the typical things, arthritis that we see in lupus after checkpoint inhibitors. We haven't. So, I mean, it's all interesting, but we don't have a lot of data.
And is it interferon systemically that was looked at, or in the joint?
Both in the joint. He's publishing that right now, but yeah, in the joint and also both in the synovial fluid and in blood.
Okay.
And there's another group in New York that presented at the American College of Rheumatology last year, and they also found a very strong interferon signal. Yeah.
Great. So on the same topic, I guess, pre-existing immunity in that theme, there are a couple of questions. So Dimitrios Makarakis asks, for patients with pre-existing autoimmunity, how is the presentation different? How different atypical are flares under ICIs? Do they present as they did before in the patient's history, or are they somewhat different with the addition of the ICI? And does the same apply to patients without pre-existing autoimmunity? I'm not sure if they.
Yeah, my experience is that for many patients, but not for all, the flare might be even much more intense than flares they had in the past. So checkpoint inhibitors might, and they may require higher doses of steroids that we would use normally, let's say for polymyalgia or rheumatoid arthritis when they have a flare. It might be more intense, but we try to manage it. And again, the steroids may damp to some degree the response, but on the other hand, we want them to be able to continue with the immune checkpoint inhibitor. And sometimes the flares that they have are much worse than anything they experience with their own disease, let's say rheumatoid before. For instance, I've had patients with psoriasis where their flare, they develop psoriatic arthritis and the flare in the skin is like nothing they've had in the past. Okay. But on the other hand, if they don't have any other options for treatment, especially if it's a malignancy that responds very well to immune checkpoint inhibitors, I mean, we try to control that to the best of our ability, even if they can get 2-3 more infusions. And usually patients, even if they are uncomfortable, I mean, most of them would prefer to get a few more infusions because they know what's in play. But yeah, typically the flares tend to be severe. Yeah.
On that note, a quick question from me here. I know Dr. Singh, Dr. Changar on the call. We have not routinely, Maria, checked CRP or IL-6 levels or ESR or CRP on patients starting checkpoint inhibition, with a very few exceptions in patients who have an already known arthralgia or some irAE. Do you see any role in the absence of definitive data of having baseline these inflammatory markers and see those change with symptoms?
I mean, you could. Cancer on its own can increase inflammatory markers, and checkpoint inhibitors on their own can also increase inflammatory markers. For us, one of the reasons why we request those is that we use a number, in rheumatology, we use disease activity measures that combine different things. So there's something that we call the DAS28, which is a measure that we use, and that's a typical measure that's used for clinical trials. There's another measure that we call the CDI, Clinical Disease Activity Index. Those measures look at number of tender joints, swollen joints, but the DAS, for instance, includes inflammatory markers, either SED rate or CRP. So for us, I mean, it's like second nature to use them for arthritis because they are part of how we measure disease activity in our patients. This is a little different because the patient has other conditions, which are the cancer and the treatment that can increase those inflammatory markers. But you can usually see that they change with treatment. And for me, they tend to be useful. For instance, I've had patients who have come with shoulder pain. And what they really had was rotator cuff tendinitis, which with, that always has an inflammatory component. So they might get worse. Okay, but I wouldn't expect the SED rate in these patients to be 80, it might be 30, but it wouldn't be 80. Then I would suspect maybe something else. And then I would do an ultrasound to see if in addition to the pain that they have, there's some effusion in the shoulder that I might treat with an injection or something like that. So, we find them useful because we use them all the time for our musculoskeletal diseases. If I were to say myositis, well, probably it's not that useful because I would trust much more the CK than the inflammatory markers. But for arthritis, that's pretty much the only biochemical parameter that we use for disease activity. And for polymyalgia rheumatica, also, it's been typical that you use SED rate as an indication for polymyalgia rheumatica to distinguish, for instance, from fibromyalgia, which is not an inflammatory disease, if you had doubts about diagnosis. So we are very used to those, to using these inflammatory markers because for our diseases, we don't have other biochemical parameters to use, arthritis, polymyalgia, and so forth. But for myositis, as I say, it's a little different.
Great. So maybe should we dive into the treatment questions? There were lots of those, and maybe I'll just start by saying that a typical patient we would see in our clinic who's on immune checkpoint inhibitors develops stiffness of the joints. We typically are not trained to see whether the joints are truly inflamed or not. They're stiff. Sometimes they are really inflamed. And knowing by experience now that these can be cumbersome to deal with at our level, we are very fortunate to have colleagues like Namrata and Sarah who have really been super responsive in seeing these patients early on. So a patient like that walks into your clinic. We are kind of holding the immune checkpoint inhibitors or maybe continuing it. The symptoms are not too dramatic, but they are enough generally that they are affecting the quality of life. So I heard a few things about using very low dose steroids, and this was not just for polymyalgia. Polymyalgia I see is, we would start 10, 15, or 20 milligrams of prednisone. But what I heard you say was even for inflammatory arthritis, polyarthritis, you would actually be starting them at lower doses, huh?
I mean, it depends on the patient. Because I'm concerned about giving too high dose of steroids that can influence the tumor response, arthritis is not like myositis. Myositis, very severe, life-threatening. Arthritis is bad on quality of life, but you can always manage a little bit with pain control. If it's only arthralgia, I always like to give NSAIDs first and not give steroids, and see if NSAIDs alone, can control the disease, and explain to the patient what the issues are. If this is really intolerable, I can give you a high dose or a higher or a dose of steroids, but we don't know if that may affect a little bit the tumor response. You will still get an effect, but it might be a lower effect than if you were not on steroids. And because with arthralgia alone, I try to stay away from the steroids if we can. With arthritis, it depends on how bad the patient is. If the patient is in bed and says, I can't even walk, then we may, I like to start with 20 milligrams, for someone who has, let's say, moderately to severe arthritis. I don't like to start at 40. I've seen many of our patients that were seen by oncologists, and they treat them with 40, 60 milligrams of prednisone to start with, because that's what they have used, let's say, for colitis or for other immune-related adverse events. I prefer to start a little lower, and then if the patient is not doing well, they can call me, in a week, because in a week we would know if there is a response or not. And then, we can always increase and add a DMARD right away. Okay. When we add a DMARD, I always talk to the oncologist. There are oncologists who don't like to use methotrexate at all, particularly in the melanoma field, because there were some signals at some point in time, that methotrexate could cause melanoma. The data is not clear, but some of them don't like methotrexate. And the other thing with methotrexate is that it might take, 6 weeks, 8 weeks, or sometimes even longer to act. So you'll probably have to keep the patient on steroids while they are on methotrexate, okay? If we can, what we have done at our institution is we have started patients, if we realize that they require a high dose of steroids, they are not gonna do okay, with 20 for a week, then 15, and trying to go and keep them at 10, so it's a low dose. We will try to get approval, because that also takes, a couple of weeks, for an IL-6 inhibitor. So typically we use tocilizumab. Often we use subcutaneous, so the patient can do it at home instead of coming for infusions. We can also use infusions. Infusions now are more or less impossible, because there's a shortage of IV tocilizumab because of COVID, because it's being used for COVID. So we often do a sub-Q, but we try to get approval, and we tend to treat them with tocilizumab. Why do we do that? Well, first of all, because there's no signal whatsoever, and I know I showed you too much data, so you may not remember, but there's no signal for tocilizumab causing malignancy per se, as a batacept, or as, which is a CTLA-4 agonist, or as TNF inhibitors, which seem to be safe, but there were some black box warnings that still remain. So we try to get approval for tocilizumab fairly quickly. sometimes it's tough, and start the patients on that. Does everyone respond? No. I've had patients that didn't respond. I didn't want to keep them on 20 milligrams of prednisone, so I had to switch to TNF inhibitors, and we've done that. I also have, patients on methotrexate that have done well, but usually that will require keeping the steroids for a longer period of time. With biologics, the effect is a little quicker. So you're able to decrease the steroids quicker and more quickly.
And when do you consider hydroxychloroquine? And I also heard you mention colchicine, which I only think of in the context of gout, but it does have anti-inflammatory properties. So before steroids, when would you consider hydroxychloroquine or some other agents?
Hydroxychloroquine, we have used that, the same as sulfasalazine, but it takes 2-3 months to work. Okay, so I think in a patient who's, has arthralgia, doesn't have, florid polyarthritis, is something that one can try, but you cannot say whether it works or not for 2 months. Okay, I mean, we know that from our studies in rheumatoid arthritis, or lupus. Almost every patient with lupus is treated with hydroxychloroquine, mostly for arthralgia and for rash, and it's very effective in that context, but it takes 2-3 months until it's effective. So if you're going to have to wait and stop the checkpoint inhibitor for 2-3 months, I would rather do something else that allows the patient to continue to receive the infusions without a high dose of steroids. So it's okay, but you have to evaluate how the patient is at that point in time, and whether the arthritis is so severe that it will not allow you to give the next dose of checkpoint inhibitors unless you treat them with 40 milligrams of prednisone, because then you are concerned about the affecting the tumoral response. Colchicine we use for a patient with pseudogout, okay, with CPPD crystals. We don't really use that for rheumatoid arthritis. Could it be used for patients with immune-related adverse events? I don't know. It's anti-inflammatory, as you say. And that would be interesting. We can probably look at our data, because we have many patients who had gout before. We have access to some claims study and see if patients who were receiving colchicine for gout. The thing though with colchicine, the way we use it in rheumatology, I don't know that there are going to be many patients on colchicine, because when someone develops gout, we typically give colchicine for 6 months, but many patients stop after that. So I don't know that there are going to be enough patients on chronic colchicine to be able to see if there's an impact on the development of adverse events. But if that were, for this particular patient who had CPPD crystals in the joint, it worked beautifully. So if we were able to treat immune-related adverse events with colchicine, that would be fantastic, because it's very low toxicity in general and well tolerated at the dose that we use, which is 0.6 milligrams. And if you use higher dose, it causes diarrhea. But that's for crystal arthritis. That's where we have used it. So I don't know for other immune-related adverse events.
Namrata, Sarah, please chime in, and I'm sure you have tons of questions.
Good morning. So nice to see you, Maria, and thank you so much for such a fabulous talk and Q&A. And I think, besides Shailendra Petros, everybody, besides the fact that, of course, she's an amazing clinician and has done so much work, I think I wanted to give a big shout out to Maria, because she's a very widely sought out mentor at MD Anderson because of all the work she's done. And I know 2 of her mentees, Noha and Maria, the other Maria, Dr. Almazor, who have gotten on case just recently, right? So many congratulations to you and your team. And I know there will be tons of work coming out on this topic, like it has so far. So yeah, I just am adoring and admiring all the work you do.
Thank you. You're very kind.
My question, if I may ask, and besides, Sarah, go ahead, please go.
Oh, no, you should go.
The question was, you said tocilizumab is your go-to biologic, and of course, as you said early on, is better because they will take time to kick in. Would you go ahead and use tocilizumab for irAE management for let's say in a patient who's actively undergoing treatment for gastric cancer or like lung cancer. So like, I don't know if you feel like, okay, for melanoma, I feel much better given IL-6 is maybe pathogenic in the melanoma pathway. So I feel anti-IL-6 is great. But like for a GE adenocarcinoma, GU cancers, do you ever feel like, okay, maybe, do you think by tumor type at all?
We don't think by tumor type because we
Okay.
have many. We don't have many other options. So in a
Right.
way, we feel more confident with tocilizumab. I mean, I personally am a little scared with colon colorectal because
Right.
tocilizumab has been shown to cause perforation, GI
Right.
perforation. So
Sure.
we are concerned with patients with GI if they have a pre-existing history of diverticulitis, which in older people is fairly common. So that's a time where I would be a little concerned about using tocilizumab.
Got it.
One of the reasons why we use it also, it's because the oncologists like it at our institution. So
okay.
There's a lot of push.
Dr. Diab, I
said,
think.
Exactly. And Noha has been working on this. Noha
Yes.
has been reviewing all of the cases.
Yes.
Again, I mean, I don't like to prescribe drugs without checking with the oncologist. That's
Right.
been
Sure.
my practice all along, because I think this needs to be a team effort. So I can tell the oncologist what I think, but I want to hear from them. And I want them to be comfortable with what I prescribe. So we always work as a team, or I work as a, I don't know if everyone does the same, even, with the other specialties, MD Anderson. But I always like to check with the oncologist and make sure that they are comfortable with anything that I do. Because I don't think there's nothing worse for the patient that I tell them one thing, and then they go to the oncologist and they say another thing, and then the patient is all confused. So I really want to be in sync with everyone. So at our institution, mostly coming from Adi Diab, who's very interesting in this, and I mean, and I don't disagree with him, I just don't know as much as he knows, because he does research on it, and has had an interest in IL-6 for a few years already. So because I don't disagree and I don't have anything better to offer to say, well, this is better than tocilizumab, I'm happy to give it to patients. That said, not everyone responds, okay? Because I've had to switch treatment.
Absolutely.
So, and I mean, for even when we use it in our primary diseases, all of these biologics only work half of the time, About half of our patients end up discontinuing a biologic because eventually they don't respond. So you just have to try. Yeah, but I mean, the reason is really, I mean, I think other people use them as well, but in other centers, they've been more eager to use TNF inhibitors if they use the biologic. Yeah.
Right. No, thank you so much. And I think to your effect of, talking to the oncologists, I mean, Petros, Shailender, me, Sarah, I think we're on a lot on text messaging and figuring out emails, epic messages, so yes, we try to be very, very, coordinate the care of the patient so that they don't get two messages from two different people.
And for our oncologists in the community, we can send an email to all the registrants, but we do have an email list where people can just submit their cases to us, and that email goes out to all the multi-D experts. So if we have an immune-related adverse event happening anywhere, if somebody wants to pick the brains of experts, that email is a way to go. And listserv email, Petros, if we can, maybe Cody or Petros, if we can just put that email address in the chat for our community oncologists. That's another mechanism to get prompt input.
That's great, Shailender. Thank you for mentioning this. And I totally echo what Maria and Amrata just said. I think the team multi-D approach is key here, communication, and Cody can put this email to the chat room. I think, Sarah, you want to comment and ask a question and before we wrap up?
Sure. I know our time is almost up. So just want to say thank you so much, Maria. I've kind of admired you from afar. I've relied on your publications a lot. So thank you so much. I have two questions. The first question is there any justification for avoiding TNF inhibitors in patients with melanoma if you have to pivot from tocilizumab if it's not working to something else? My second question is getting to your point about kind of like this balance. You know, our job as the rheumatologist is to get out of the way and to allow the cancer to be treated. You know, oftentimes my experience with some patients is that there's just kind of like an ambivalence in terms of like whether to go ahead with DMARD therapy. I mean, some people are really wanting to kind of suffer through it. Some people are not quite sure how it affects their quality of life. And so maybe this is more of a patient-oriented research question, but I was just wondering if you had any ideas, if anyone is studying the creation of some sort of like disease, like some sort of tool in the clinic, a decision helping tool that someone like myself could do with the patient to kind of help them decide if it's worth it to go on a DMARD or not?
Okay. Well, the first question, I think we are always concerned about things that we don't know. So we don't know if a TNF inhibitor in a patient with melanoma might make a recurrence more likely or not. But at some point, you need to think, is there anything else I can treat this cancer with? And if the patient has not responded to other things, I mean, you go for what you can. I mean, that's how I see it, especially because checkpoint inhibitors are so effective for melanoma that in a way, I mean, you may be abrogating the effect to some degree, but again, you know, I would prefer to use something else, but I mean, if by giving a TNF inhibitor, I'm able to get the patient to continue the checkpoint inhibitor therapy in the absence of data, that's what I would do. Okay. Your second question is very interesting, and we struggle with that, as you do every day with our patients, because as you say, everyone is different. And some patients say, this is the most important thing for me. I want to maintain my cancer treatment no matter what. And others say, I just can't stand the pain. I cannot take this anymore. We are not doing anything right now for patients who have immune-related arthritis as far as decision aids, but one of Maria Lopez Olivo, one of my collaborators, she has a K award from NCI to develop a decision tool for patients with pre-existing autoimmune disease, okay, to help them make decisions. So it's not just patients with rheumatoid arthritis, it's also patients with psoriatic arthritis and with ulcerative colitis, and I can't remember what other pre-existing diseases she has right now. But the idea is to build a model where we can show the patients, I mean, it has to be in a way that's patient friendly because you don't want to scare them. But what happens if you decide to take the therapy, and what happens if you don't, if you decide not to take it? And we might be able to incorporate a little bit the treatment. The problem in incorporating treatment into those decision tools is that we don't have data. So I cannot really tell a patient, if you are taking 30 milligrams of prednisone, your cancer is going to be worse. I can't, because I don't have the data. You know, it's when I showed the data that we have for rheumatoid arthritis and biologics and incidence of malignancies. I mean, there's tons of studies, and some of them are national studies, like the Swedish ones. But for immune checkpoint inhibitors, we just have small case series, 50 patients who took steroids or whatever. We don't have the data to be able to build that with certainty. And you can have tools for patients where you just tell them about the uncertainties. You say, this is the area that we don't know much about. So you make your decision knowing that this is unknown, that we cannot inform you on that. So yeah, that's one area that we have been doing. I also have a grant where we are actually looking at patients with rheumatoid arthritis who have cancer and what the effect of biologics might be and how to build a tool that can help them. But this is outside checkpoint inhibitors. I mean, there will be patients who are also taking checkpoint inhibitors. I mean, with respect to someone who develops arthritis de novo as an immune-related adverse event, I think it would be wonderful to have some tool that can inform patients of the benefits and harms of the different treatments for that immune-related adverse event, but I don't think we have the data yet to build it.
Mm-hmm. I look forward to that for the pre-existing. We'll look out for that. Thank you so much.
It's an opportunity for sure for more research and registries and databases. I think we can definitely learn together, and I'm very, very supportive of this effort. And I know Namrata, Shailendra, and Sarah will try internally to develop these databases and hopefully collaborate with Maria and her team. I think there's such a fantastic interactive discussion today, and in those circumstances, I never want to stop, because I'm learning here, like all of you do. But unfortunately, we're running out of time. Like all the good things end quickly. So I will let Shailendra close up, but I want to make a couple of comments. Number one, thanks, Maria, for a wonderful presentation, answering so many questions, covering so much data in a short amount of time. Really, really wonderful work and contributions in the field. Number two, we want the feedback from the participants. So please, I think Cody sent out a link for feedback and comments. We want to further improve, and we want to get your feedback from that and evaluation. Number three, there's a number of papers that we posted in the chat room, and Dr. Smith had a great suggestion to share them through email. So Cody, I think, is tasked with this. And Cody, we can share these manuscripts if need be. And the last thing I would say is this listserv that Shailendra shared, for now, for the moment, is only for the internal SCCA UW team, but we're working towards a mechanism to expand this, even in outside external providers, because I think it's a great resource when resources are available. So stay tuned. Our tumor board, irAE tumor board, is open to everybody, and people can comment and even present cases. So Cody, maybe you can, in the next email to participants, you can also share the link for our next irAE tumor board next Friday. Actually, I thought, no, 2 Fridays from now, October 22nd. We do this almost monthly. Again, thanks everybody for joining, and thanks, Maria. Shailendra, I will let you close.
No, I don't have anything else to add, Petros. I just am in great appreciation for your time, Maria. This was fantastic. And, the main purpose of this is for all of us to get together and maybe think differently about how we are doing things, or at least, have some opportunity for cross-fertilization of different ideas. So this was great. Thank you so much for joining us, and everybody. We will look forward to our next event.
Thank you so much for the kind invitation. And thank you, Sarah and Namrata, for the good work you're doing there as well.